Good morning, friends. I'm going to reshare again because I lost my screen, which doesn't help. So good morning, friends. Welcome to the Transformativa Elders Project. We are delighted to have you here. I'm delighted to introduce to you our host and our first very special guest today in just a moment. A few things I want to go through first. My name is Chris Erickson. My slides aren't working. There we go. This is me. And I'm the managing director of the Transformativa Elders Project. And what we have done is we have gathered who we believe are trailblazers from across the country. Ron is our first guest, but these are people who have been integral to the development of behavioral health over decades. And we just think the rest of us need to hear from them on a fairly regular basis. So we're going to do that. There's going to be opportunities in the future. We're going to do a dialogue every month with an elder. And there's going to be some opportunities in the future, too, to join an elder circle. They will be sharing some of their writings with us. So looking forward to those kinds of things in the future, too. This session is being recorded, just so you know. I would appreciate it if you would stay on mute during the dialogue. There'll be time for questions at the end, and you can put those questions in the chat anytime during the discussion, and we'll get to them as we can. We have a CEU available today, and I will be sending to you an evaluation after today's session that if you fill that out, it allows us to generate a CEU certificate for you. So now I want to introduce you to two very, very special people in my world. Jim Clarkson is the chairperson of the VIA family of companies, and Jim will be our host today. He serves on numerous boards and in advisory roles to the nation's leading healthcare providers. Jim served previously as a national vice president with Value Options Incorporated, the national largest private behavioral health and wellness managed care organization. With Value Options, Jim was responsible for enterprises in emerging market areas, managed state substance abuse delivery systems, and served as an internal and external substance use disorder subject matter expert. Previously, Jim led both behavioral health and substance use disorder treatment agencies and worked as a clinician for many years. He provided consultation and training nationally and internationally, including for the U.S. Department of Health and Human Services, SAMHSA, HRSA, and NIATEX, among many others. Jim has worked and consulted with programs across the country, focusing on the connection between spirituality and wellness, mental health, addiction recovery, and financial literacy. He managed the Healing Circle at the Institute of American Indian Arts in Santa Fe and has worked with pueblos and tribes around the country. For more than 35 years, Jim has helped Fortune 500 companies and public healthcare systems create environments for recovery, sustainability, and positive therapeutic outcomes. Jim, thank you for hosting today. Our special guest, Dr. Ron Manderscheid, who has a lifelong commitment to social good and social justice, reflected through a career that spans national work with the Congress and administration, federal agencies, NGOs, and university teaching. Currently, Ron is a partner and director at Capstone Solutions Consulting Group, an adjunct professor at the Bloomberg School of Public Health at Johns Hopkins University, and at the Suzanne Dworak Peck School of Social Work at the University of Southern California. Until recently, he was the president CEO of the National Association of County Behavioral Health and Developmental Disability Directors. I still, Ron, think that's just a really long name. And National Association for Rural Mental Health. Both organizations represent county and local authorities in the DC community. He also serves on the boards of the Global Leadership Exchange, the NASHBID Research Institute, and the Dania Institute. Until recently, he was the co-chair of the National Coalition for Whole Health and on the boards of the American Academy of Social Work and Social Welfare and the National Grand Challenge for Social Work Initiative. His past appointments include, among many others, the Director of Mental Health and Substance Use Programs at the Global Health Sector, SRA International, and several federal leadership roles at the National Institute of Mental Health, SAMHSA, and the Office of the Assistant Secretary of Health. Throughout his career, Ron has emphasized and promoted the concerns of peers with behavioral health conditions and their family members. So I welcome you. And Jim, I'm giving this to you and Ron. Thank you both for being here today.
Thank you so much, Chris, for a beautiful, and thank you all for joining us today. We're really excited about this Transformativa Elders Project. And many people have asked me, as we've invited people to join us, what constitutes an elder? So I went about looking for definitions of what an elder is. And ultimately, this is someone who has blazed a path just further down the road than maybe the rest of us have gone. And one of the things that we found in our work over the last several decades is we really have gotten to work with and meet some of the most incredible national leaders in behavioral health. And as they start to retire, we start to work with and hire younger generations of up and coming experts and consultants and colleagues. And one of the things that we saw right away was, wow, some of the very same questions that our younger colleagues are coming in with are the very same issues that our elders in the field have previously addressed over many, many, many decades. The other thing that you may know, and so the opportunity here is to bring that wisdom together. The other thing that is sort of a core value at Via Positiva and the companies that we work with is presence and process is as important as product. And so as all of us develop systems in our various areas of influence, one of the things that we believe is that the quality of individual relationships really equal the sum total of what the quality of a system. And so we are so excited to have Dr. Ron Manderscheid, who has really made a career of distinguished accomplishment, but also by every account, a beautiful, compassionate quality of presence. And so, Ron, we really appreciate you helping us kick off our series here, and welcome to you.
So, yeah, thank you very much. Thanks very much to Chris for a wonderful introduction. Thanks very much to you for hosting today. I guess where I would start is saying, it's been my entire privilege to have been able to have a 40+ year career in behavioral health, working in mental health, working on substance use issues, and also working on public health issues. But amazing changes have occurred during that period, and I recently did a blog on the changing paradigm for behavioral health. When I came to the National Institute of Mental Health as a graduate student 40+ years ago, the underlying paradigm for mental health was, this is a chronic relapsing condition with no hope for the future. You're going to be with us forever. You're going to be in a state hospital the rest of your life, and so on. That was the overall paradigm. That was in the research world. That was in the training world. That was in the practice world. So then to fast forward that over time up to 2000, we got the concept of recovery. Bring it down to today, we have a very different paradigm. We have a paradigm of trauma-caused disease with the hope of recovery. That is just an amazing, amazing shift in that period of time. And amazing things were able to happen in the field because of that particular shift. So I just want to make note of that. And I would also say to everybody who's on, if I can help any of you in any aspect of your career, you want some advice, you want to talk to somebody, I'm always happy to do that. So I'm always around. I'm always available on Zoom. I'm always available on my phone, or I'm always available by email. Would be very happy to do that. So Jim, I'm going to turn it back over to you here.
All right. Thank you so much, Ron. Really appreciate those initial insights, and we'll follow up on some of those. Clearly, you've done so much in and for our field, And I'm just wondering, what do you feel were the most important? Maybe they were not the most visible, but the most important contributions that you've made to our field over many years.
So some of the things that I've worked on that I think are most important from my perspective would be things such as bringing the consumer voice to the federal government. So a little bit of history on that. So as I was in my career, about midpoint in my career, I started hearing a lot of stories by primary consumers when I would be out in the field. And no matter where I went, these stories were always very similar. It was always the case where someone had experienced trauma. It was always a case where that trauma had had a lot of consequences for that person. It was always a case where there wasn't quite a fit between that person and the care they were receiving. It was always that type of story. People frequently didn't have help from their family. They didn't have help from friends and so on. And I've always kind of viewed that process as when you become mentally ill or you develop a substance use problem, you lose your voice. Nobody pays any attention to you anymore. And so that's what I was seeing among consumers out in the field midpoint in my career. And I said, well, one of the important things that we really need to do here is we need to bring the voice of these experiences back to the federal government. So I started inviting primary consumers to my various groups. I had technical work groups, I had review work groups, had various advisory work groups, and whenever I would have one, I would always bring a consumer. And we learned. We didn't know how to do this when we first started. We learned, number one, you can't bring a single consumer. We learned, number two, you probably need to make accommodations for that person. Many people have a dog or an animal that's a part of their recovery and so on. You learn that you can't give someone too big an honorarium or they'll lose their SSI. We learned all that through that process. And this was going on about, I would say 1990 in that period, 1985 to 1990, I was doing a lot of this. And when I'd have a major meeting, and I hosted at that time a major meeting of about 500 people every year, I would invite primary consumers to be plenary speakers to come and talk about their experience. And what always shocked me is how little the people in the audience knew about the primary experience of consumers. It was amazing. And so we did that. We persisted in it. Professionals didn't always like it when we did these things, but I thought it was very important. We kept doing it. We continued to do it down to today. So if you go to NIMH or SAMHSA or anywhere today, and basically anywhere in HHS, virtually every field has primary consumers there providing advice to the federal government. And I think SAMHSA is a primary example of that, and there's a significant portion of the staff now of SAMHSA who are primary consumers as well. Does that mean the work is done on this? Of course not. There's more work to be done here. For example, one of the visions of bringing primary consumers in to advisory groups was that they would be at parity. So if you had a group of 12 people, half would be primary consumers or family members, and the other half would be professionals or paraprofessionals of various kinds. We have never gotten to that point. We've gotten to the point where we have a few in many groups, but we've never gotten to the point of parity. Secondly, we've never gotten to the point where primary consumers actually operate the major programs. We've had some recent examples where we've come close to that in SAMHSA. I think part of that was thanks to Pam Hyde, who I see is on here today, where Pam, I think, completely recognized that this is the direction we need to go, and that primary consumers bring us a lot of information and a lot of insight that we may not have if we are not primary consumers. And to Pam's credit, I believe a previous director of the Center for Mental Health Services was a primary consumer. The principal deputy, the most recent principal deputy in SAMHSA was a primary consumer. There are examples where these people are beginning to emerge in leadership roles, and I think that's all to the good. So that's one area that I spent a lot of time working on. If say what you're most proud of, that's the thing I'm most proud of anything I've done in my entire career. I want to talk about a couple of other things also here. Another area where I've spent a huge amount of time over the last, I would say 35 to 40 years, is on integrated care. So I go back a very long time into the 1980s in NIMH, and we did some research in NIMH in the middle 1980s, and it was very interesting research. It showed that people with mental health conditions develop chronic health conditions earlier, and that those chronic health conditions are more severe in people with mental illness than they are in other populations. And we published this material in the middle 1980s. And then there was discussion in NIMH, if this is a problem, how can we address it? And what is the appropriate role of a primary care physician in this? We were into this in the middle 1980s. If you kind of then fast forward up a little bit into the 90s, we had the Surgeon General's report on mental health in 1999. That report actually said the next decade of work for mental health is integrating mental health and primary care. And for many reasons, that didn't completely happen in the first decade of the 2000s. I know the Surgeon General made an effort to have it happen. It didn't happen for various reasons. And the actual implementation of integrated care has been somewhat retarded in the field. So if you come forward even a little farther here, I was involved in doing some research in the middle 2000s on premature mortality of people with behavioral health conditions. And even I was shocked by the findings. The basic finding of that research, and I had data from 8 states. It was 100% data, it was not sample data. And I had 3 years of data from each state. So I had, in effect, 24 replicates of the data. They were all 100% consistent. On average, a person served in the public mental health system at that time was dying 25 years younger than other people. Died of the same things other people died of cancer, died of heart disease, died of various types of digestive disorders and so on, but just died 25 years earlier. If I multiply the disorders, say, well, you're not only mentally ill, but you have a substance use disorder, I could literally get those numbers up to 42 to 45 years. Amazing. More than half your life taken away by these disorders. So we published that, and I think that work had a significant impact on how behavioral health fared in the Affordable Care Act of 2010. I think that work and the advocacy that was done around that work helped us get the parity legislation in 2008. And you all know what the parity legislation is. And the parity legislation then helped create a place for us at the table in 2010 where behavioral health was fully considered with all the other diseases as part of the Affordable Care Act. And I would argue that was probably the first time that ever happened for behavioral health care. So if you keep on coming down to the present in integrated care, the Affordable Care Act said several things. It changed our philosophy a little bit, saying, we want to focus on whole person care, looking at the whole person. Don't look at a person as a diagnosis, look at them as a person. And we want to then build our care systems to reflect that whole person. So there were a whole series of grant programs and so on that came about as a result of the Affordable Care Act that first started being implemented in 2014. And I was out doing a lot of talking about this at the time to my members in NACBID. And what I found was as soon as I talked about integrated care, people were not hearing what I was saying anymore. As soon as I would talk about that, they would shut down. And why would they shut down? Because what they were hearing is he's coming and telling us, I'm going to lose my job or my organization is going to go out of business. So we had to adapt what we talked about around integrated care so that people didn't reflect that. And it's obvious, you're not going to lose your job. We have far too few people working in behavioral health care. At the best of times in mental health, we only ever serve 50% of the people with mental health conditions. Substance use, we've finally gotten it up to about 20% now. We are way behind the 8 ball in terms of our capacity here. So it was not a problem of capacity. It might have been a problem that your organization would be integrated with another organization and so on. That problem, the second problem, became overcome when we had virtual care. So when the COVID issue came along in 2019, 2020, we went overnight from in-person care to virtual care. With virtual care, you can do integrated care instantaneously. You don't have to have any organizational change to do it and so on. That has made a huge difference in the implementation of integrated care. And you bring that up to the present a little bit here. CMS has a new program actually for states on moving the integrated care agenda. I think it's called Program for Integrated Care, where they are trying to put together behavioral health and primary care and what's now called social care, linked under the auspices of behavioral health entities. And the beginning of this program, I think CMS was going to invite states, and states could volunteer to be among the first 8. I think they're in the very earliest phases of this, but I'm very optimistic that this is actually beginning to move along, and it's targeting in both Medicaid and in Medicare. I also have done a paper fairly recently that I published on basically stepping into the future of integrated care. People are interested in that subject. I'd be very happy to share that with them. But integrated care continues to be a long-term interest of mine and will continue to be until we actually are able to change the problems that I was discussing. Chronic disease in people with behavioral health condition and premature mortality. I also am just completing, but it's not published yet, a paper on premature mortality where I looked at what we had done in the early 2000s, looked at the history of this back literally to about 1900, and then coming forward said, well, what work has been done in the meantime? And the headline of the work that's been done in the meantime is the fact that nothing has changed. So if you ask me, well, what changed since you did the study in 2006? I would say nothing. The same problem at the same level is out there today as it was in 2006. We've spent billions and tens of billions of dollars. We have not solved the integrated care problem in a way that it has had an impact on premature mortality. And in at least any of the US studies that I reviewed or any of the international studies that I reviewed. That's another area. One third area, and I don't want to take up too much, I'll stop here in a minute or two. I want to talk about the work I did in healthcare reform. I think that's very important as well. So when the Clintons came to office, the Clintons created a work group of 538 people to work on healthcare reform. And they literally did that within less than a month of them being in office in 1993. And there was a work group for behavioral health, and I had the good fortune of being on that work group and did a number of very interesting things. Part of my role there was to meet with the people from the disability community, to communicate with them what was going on in the work group and to receive input from them on what they thought we ought to be doing as part of national healthcare reform for the disability community. One very important thing. Another thing I did in that group is I was the liaison between the behavioral health group and the workforce group. Workforce group met for quite a long time. Everybody knew that if you're going to address the problems of workforce for health or behavioral health, you need to have national standards. It can't simply be state by state, where if you walk from one state to another, the standards are very different and so on. They talked on and on and on about this. In the end, they said, we all know this is true, but we aren't going to do a thing about it, because if we do that, we're going to kill the entire bill. So nothing was done about this in any health field, including in behavioral health at that time. Then I went on and I was assigned to the office of the Assistant Secretary of Health to be the person who monitored the 5 pieces of legislation that were going across the Hill, that were proposed by different people in the House and Senate to reflect the Clinton health reform bill. And that was a very exciting 18-month period. We did a lot of different things. What we were able to do, in fact, even though ultimately none of those 5 bills ever saw the light of day, we were able to take pieces out of those bills and put them into other bills. So virtually most of what we had talked about in health reform actually happened, but it didn't happen as one piece. It happened as many pieces over a period of time as we went forward. I also had the opportunity to participate in working on the Affordable Care Act in 2009, 2010. At that time, I was at NACBID, so I said, we need to be involved in this. So I reached out. I literally reached out to the woman in the Senate who was writing the if you can believe that. There was one woman, a woman named Catherine Dratz. Catherine Dratz is a real person. Catherine Dratz is the person who wrote the Affordable Care Act. So I would go and have breakfast with Catherine Dratz once every 2-3 weeks, and we would talk about some different features of behavioral health. And the reason I did that is for the effort of trying to get a more focus on behavioral health into the Affordable Care Act, and to help her understand some of the nuances of behavioral health you would not understand. She was not a person trained in health or behavioral health. She had a master's degree from the University of London in Shakespearean studies or something like this. So a very different, very good writer, wonderful writer, but she didn't start by having the content. So I tried to be helpful for that. And of course, was delighted when the Affordable Care Act finally was passed and it had some mental health content. Hopefully I was able to contribute to that. So if you ask me what are the most important things I did, those are some examples of that, basically.
Ron, thank you so much. Clearly, you are a trailblazer and have really laid the groundwork for much of the work that we do now, certainly around trauma. I used to say and still say, when I was a clinician, there was not a single client that I saw over decades whose substance use disorder was not driven in some way, shape, or form by significant trauma. The consumer voice that we have peers here who are on the call, and the continuing efforts to utilize the consumer voice and the consumer expertise to help guide our field. Integrated care, we're still, as you said, what has changed from 2006? Not much. We have a lot of work to do around that. Premature mortality, absolutely, and still sadly true, but hopefully getting a little bit better. Parity, which we know now, at least in the headlines, is a bit or a lot at risk. We're not sure. And workforce. So we're all really still carrying the ball forward, I think. And I'll circle back with a question toward the end about how we might be able to do that, get some feedback on how we might be able to do that better or differently. But I really also wanted to get a sense of who you are personally, and what has sort of shaped you to be in the leadership and have such a broad circle of influence and influence our field for the better over many years. So I was wondering if you could tell us about your formative years and the influences that have shaped you as a person, who you have become as personally and professionally, and the people or the experiences that really shaped your work.
Yeah, so it's a very interesting question. So I think the way I would answer, so I began by I'm a person from the Midwest. I'm not from the East Coast or the West Coast. I'm a person from the Midwest. And I was raised very near La Crosse, Wisconsin, to put me on the map here. And so the way I would describe the culture that I was raised in is a combination of being raised in an environment like Huckleberry Finn on one hand, and the other hand, Lake Wobegon. So it was a mixture of that and the community. And I think you all know exactly what I'm talking about when I say that. And it was a very, grew up in a very small community. And some of the things I majorly remember is when after school, we would organize a team. At the one season, we played softball. Another season, we played baseball. Another season, we played football. But we organized everything ourselves. And I think that's a huge difference between what we had then and what's now. Uh, what's now is everything for a child is organized by adults. So if they're out playing softball or baseball or football, an adult is putting that together. When we did that, we put it together ourselves. We didn't always agree, but we worked out the disagreements. And I think part of the loss we've had is you can't do everything for children. Children need to learn to do things and make mistakes, fight it out, work it out, all these types of things, and we don't let children do that. So I think that was a very important part of my upbringing. Also, being from that environment, that small town environment, we knew everybody. So whenever anybody had a wedding or anybody had a funeral or they had a new baby in the family, we always participated in some way. We did something for that family, and the community got together and did things for that family. So it's that kind of environment that I grew up in where, I tend to be more outgoing with people, I think. I tend to try to engage people as friends and so on, and like to do that. And I think that's due in part to my upbringing. A couple of other things, and a little later on here, the way when I first started working in mental health, it was a serendipitous thing. So I was in graduate school. An opportunity came along in the summer to go and work part-time in a facility called the Mental Health Study Center. And the Mental Health Study Center was the community laboratory for the National Institute of Mental Health in Prince George's County, Maryland. So I had an opportunity to go and work there in the summer, and I had an opportunity to work there in the fall and winter and so on. But it was totally serendipitous that ever happened to me. Had that never happened to me, I probably would not have spent the next 40 years of my life in the mental health field. I was being trained to be a researcher, basically to replicate my mentor. What you do in the university, your mentor trains you, and then your mentor kind of expects that you're going to go on and follow your mentor in the similar role in the university and so on. I never quite did that. I went to NIMH as a student and as a part-time student and so on. But I then also always taught part-time. So all throughout my federal career, I taught for 20 years for the University of Maryland. Then when I left the government, I also then started teaching for Hopkins and more recently have taught for USC as well. So I had my finger in teaching, but not really the way your mentor would want you to do that as your mentor if he were your research mentor. So I think, that was totally serendipitous. Had I never gone to NIMH to do that, I probably would not have had a career in mental health. Another very interesting thing that happened at that particular time. So when I went to NIMH, I had the opportunity to work in the labs of NIMH. So in addition to being assigned to the Mental Health Study Center and as a part-time person, I also worked with a man named Julius Axelrod, who was working on the brain catecholamines. And it was very, very interesting work because he was having the beginning understanding of how electrical impulses get transmitted between the dendrites and neurons in your brain, basically. And what are the chemicals that exist at those synapses that allow the transmission of those electrical impulses? And what happens when you have too much neurotransmitter there and too little neurotransmitter there, and so on? Very, very interesting work. And the very first theory that we had of schizophrenia from that brain work was that schizophrenia involved an excess of neurotransmitter in the brain, and depression involved a deficit of neurotransmitters. So all the generation 1 and generation 2 of psychiatric meds come from those essential ideas. So you're either enhancing the neurotransmitter in your brain if you have depression. So the serotonins and all those things are enhancers, or you're mitigating, you're reducing the level of neurotransmitter at those synapses. And there's a whole series of psychotropic meds that do that. So that was just very, very interesting, because what that did for me, I was not a person. So I had some training in chemistry, but I wouldn't say I was really a chemist. I was able to combine some work in chemistry with work in psychology and social interaction, basically. So you get to the question, how do these neurotransmitters in a person's brain relate to their psychological state, what they think of themselves, how they're interacting with people in the environment, and so on. Is very, very interesting work. And I started as a student, then I went on and I was a contractor, then I went on and I was an employee, and I was involved in that kind of work, biopsychosocial research, for really the first 10 years of my career in the National Institute of Mental Health. And we published in that time about 100 papers on these things. These papers are out in the field on various topics and so on. But I think that also had a huge influence on me and how I look at things. I guess I feel kind of badly we don't do very much biopsychosocial research anymore. That was kind of the golden era where this type of stuff was going on. Very little of that is happening these days, and I think it's to the detriment of the field. For example, if you take the problem of trauma that I talked about a little while ago and say, well, what does trauma do to you? And what does trauma do to your brain? What does trauma do to those neurotransmitters in your brain? I don't think we look at those problems anymore, and I think that's unfortunate. Therefore, I always, when I give talks and people say, well, can you give an introduction of yourself? I always say my career went from the bench, literally the bench, to the trench. So I went from the bench working on neurotransmitters and so on as a graduate student, out into the trench working in places like NACBID, and now doing advocacy and all these kinds of things that I feel I've had a very rich time being able to be in that expanse of things, actually, and have enjoyed it. Final comment here on this, another part of my own background that I think is very important is when I moved on from the Mental Health Study Center, and I didn't move on because I wanted to, Ronald Reagan came along. Ronald Reagan closed the community laboratory of the National Institute of Mental Health. It stopped being in 1981. And I moved over to the headquarters of NIMH. And when I moved over to the headquarters, I ended up in the Division of Biometry and Epidemiology of NIMH. And that division was totally public health focused. So I became involved in public health. I became very involved in epidemiology. I was involved in the first national epi study in mental health, the epidemiologic catchment area study, and so on at NIMH. And I think my framing in public health also has influenced me in the subsequent period, in all things I do. And if you now kind of walk to the problem and say, as we're moving from, we can't just be clinically focused, we also have to be community focused in what we do and work on the social determinants of health. You have to use a public health model to do that. And I guess, appreciate the fact that I started in public health so long ago and have always belonged to the American Public Health Association, have gone to many, many, many of their meetings, was the chair of the mental health section of the American Public Health Association, and on and so on. And so that kind of gives you a flavor for where I came from personally and where I kind of came from professionally. But I think serendipity was an important part of a lot of that, basically.
Interesting. So interesting, Ron, that your career actually sounds like it really sprung from your experience. And I can certainly relate to this as well. I'm sure many others, of getting outside in the backyard and in the fields with other kids and organizing for ourselves,
Yeah.
soccer games, baseball games, football games, all the other things that we did, shenanigans we were up to, but we were
Exactly.
organizing
There were a lot of
together.
shenanigans involved in all of this
That's
that I
right. That's
haven't
right.
talked about here. Yes, exactly.
Yeah, and you know the sense of community that we were really all in this together. So if Mrs. Jones, who may not have been nice to us down the street, has an issue, yeah, we're still going to go support and help and stay connected. And then your career sounds very much like organizing and researching and going from the bench to the trenches, you said. For a follow-up question, I would have maybe a couple. One is, you know, in all of that, what was it looking back that you found the most joyful or blissful in that pathway? And then if there's any message that you could give your sort of fresh-faced out of undergraduate or graduate school self, words of wisdom going forward, and by sort of extension, what might you say to the younger people who are starting off in our field right now? So it's sort of three questions about joy, about giving a message to your younger, fresh-faced self, and as well as giving words to folks that are coming up behind us.
So I would say, in terms of joy, the joy of being able to do something for someone or to help someone do something for themselves that they could not do without external help. My example of, bringing consumer voice. Consumers wanted to have the voice. They didn't have a vehicle for making it happen. In a certain sense, I became the vehicle for helping them do that. Or many instances, know many people over the years. I worked with many people on their doctoral dissertations, et cetera, helping them put together the thoughts for their doctoral dissertation, arguing it out with them, et cetera. All those kind of things are things I've greatly enjoyed, throughout my career. Having a good intellectual argument about a piece of research and how you put it together or shouldn't put it together and so on. Great joy in all of that, basically. Some of the things, the lessons here, values are very important. So I guess in a certain sense, I've always believed values are very important, but if I were telling my young self, I think they're even more important today because of the changes in our general environment. And part of your grounding as a person is the values you have. And your values come from your family, it comes from your religious background, et cetera, but they're just very important in grounding you, especially in environments that have little grounding. And I think we have much less grounding these days than we have had historically. So I would say that's important. I mentioned serendipity before. Everybody's going to have serendipitous experiences. If it seems like a good opportunity, take advantage of the good opportunity. Had I not gone as a part-time graduate student to NIMH, I would never have had the career in mental health, basically, as an example. Opportunities come in different times, and you should consider all opportunities, but you probably shouldn't take every opportunity. You ought to do a careful plus minus analysis of opportunities to say, well, this could be good for me in this regard, but could be bad for me. You need to weigh it out. You shouldn't just be weighed, oh my God, this is a wonderful thing. I just need to do this. You need to be more analytical of these things, I think, as well. And then finally, I would say another important thing here, be very grateful to people who have done things for you. Every one of us on this call today, when I say that, people come into your mind, you say, I should be grateful to my local parish priest for doing this for me when I was a little kid. Or I should be very grateful to my mentors I had, when I came to the National Institute. That is just very important. Gratitude is a very important thing. And gratitude not only expresses your feelings to someone else for something they have done for you, but it also is good for you because gratitude is good for your health and it's good for your happiness, your own happiness. If you're a very ungrateful person, I'm going to predict you're going to be a fairly unhappy person. Grateful people tend to be more happy. And I've written an article on happiness where I've argued these points if anybody is into it. But those are the kinds of things that occur to me as being important here. Mentors, let me say just a word about my own mentors. So would say I had 3 mentors when I was at NIMH. My first mentor was Dr. Julius Axelrod, the man I worked with on the brain catecholamines. He was there. He always said, I had to win the Nobel Prize in order for NIMH to promote me. He thought that was a very funny thing, actually. But he was he helped me to think, be able to think things clearly. To give you an example of this, where he got the idea of the brain catecholamines was he was a person from New York, and he was walking in Central Park one day, and he looked at a dandelion. And he said, what is it about the dandelion that caused it to be open in the daytime and closed at night? Well, that is the essence of the concept of a nicotine receptor, an opioid receptor, a neurotransmitter receptor in your brain. That's exactly how the mechanism. He took that associational idea and then applied that idea in his own work in the lab, basically. So I would say he was an important person. Another important person to me was a person named Carl Tobe, who's been dead for many, many years. I would say what Carl taught me is how to do things in the bureaucracy and to be able to get around bureaucracy. If you follow every bureaucratic rule in the bureaucracy, you will never accomplish anything, literally nothing. You have to be able to cut the edges of the bureaucracy a little bit. And Carl was very good at that, and he taught me a lot about that. And my third person here is Max Schneier. Max Schneier was the father of a girl who had schizophrenia. He was a clothier in New York City. As soon as his daughter developed schizophrenia and he saw how the system was not helping his daughter, he stopped being a clothier. He went to graduate school and became a trained lawyer, and he spent the rest of his life, probably the last 40 years of his life, arguing the case for people with behavioral health condition. And he argued with the secretaries of HHS, he argued with people like Ted Kennedy and so on. I would say Max Schneier taught me how to have heart, and he was just a very wonderful person. Most people were scared of him because he would be arguing these points, but he actually was a very wonderful person with a lot of heart. And I think it's very important to have heart if you're going to do these various things, basically.
Thank you. Thanks, Ron. I'm really struck by how the very first thing you said were values are really, really important, that our values shape us, the values that we learn and the values that we choose, and how serendipity. I love that you're including serendipity and gratitude in this conversation, because there are many people on this call who I am grateful for, and I know I wouldn't be able to be doing what I'm doing right now without their help and support. And also in that gratitude, being able to pass that on to others who I mentor and work with, and what a important underscore highlight to highlight the gratitude that we have for people who've come before us, for people that we're working on now, and for people that we're laying the groundwork for in the future. And one of the things that we're really trying to do with this Transformative Elders project is really nurture that cord, that fiber optic or whatever you want to call it, between elders and people who are who could benefit from the incredible wisdom like you're offering today. I guess what I would ask next would be like, what concerns do you have about the field right now, and especially that's just went through a tectonic change in the last since early this year. What are your concerns, and what are some of the things that we might be able to do to address them together?
So that's a very, very important question, and I knew it would come up here. I would say first, in the context, the tectonic change is not over here. And what I mean by that is you've had an action taken, but the counter reaction isn't complete yet. And the counter reaction includes things such as lawsuits, federal district court lawsuits. So there've been 75 plus federal district court lawsuits. More than half of them, more than 35 of those federal district court lawsuits have been found in favor of the plaintiffs, meaning they've been found against the administration. And they're typically found on the basis that, the actions that are being taken are illegal. They are beyond the authority of the president and the administration to execute, and can only be done by the Congress, et cetera, et cetera. And all these things are going to work their way up through the courts into the Supreme Court ultimately, and so on. Number one. Number two, the states have stepped up. The states have stepped up. There are two current major cases. One case is being brought by the State Attorney General of California, with probably, I'm going to say, 18 to 20 other state plaintiffs against the Trump administration regarding specifically the problem of the reorganization of the U.S. Department of Health and Human Services. A similar case has been brought by the State Attorney General of New York, again with 18 to 20 plaintiffs, for the same reason. So this is getting organized not only on the single plaintiff level, individuals or individual organizations, but the states are getting involved in this as well. And I'm very happy to see that these things are happening going forward here. And I would say the third level of reaction here is we haven't yet had a reaction from the Congress. The Congress has not passed a single piece of legislation that's going to take down HHS and redo it the way the administration has proposed to do. It can only be done by the Congress. It cannot be done by the administration. That's going to all be haggled out, et cetera, et cetera. So, and then I guess the fourth reaction here is from people in the health community and people in the behavioral health community. 10 of our or 11 of our large mental health organization leaders have signed a letter on this, et cetera, et cetera. We need much more advocacy, but the process has started. The process has started here. So I don't think what appeared to be the original tectonic shift will be sustained going forward here. I think a lot of this is going to change in other directions, some of it moving back to where it was in various ways, some of it moving in ways we probably don't even completely know today. But I think you have to stay on top of this and watch it evolve. And I think every one of us who's on this call today has a moral obligation to be involved in this action. And, I don't even need to go into the details about what social justice means here and equity and so on. Those are absolutely critical human values that have been recognized internationally for decades, going back to the founding of the World Health Organization and other entities. So I think we all need to be involved in this and play whatever role we can. we have an obligation not only to consumers, but to future generations in the United States, the children who are growing up in the United States right now. The elders, you talk about the elders are going to need nursing care in a few years, and on and I can go on and on and on with that. We have an obligation to be involved in that. Having said all that, let me say one other feature of this, and I've been doing this in talks that I've been giving this spring. I think I have observed for a lot of people that I know in behavioral health, when these things happen, they became very upset psychologically. And I'm sure every one of you know people who are very upset psychologically because of all the things that are going on. So when I would give these talks, I would said, so the first point here is you need to take care of yourself. Don't let yourself become sickly. You need to take care of yourself, first off. Secondly, you need to spend a lot of time communicating with your friends because they can provide support to you on some of the issues you're having here. A lot of people became depressed over these things. A lot of people developed anxiety over these things. Your friends can help you with that. And third, you cannot solve all these things. You're deliberately being confronted with a situation where thousands of things are happening simultaneously. That is a strategy to overwhelm you. Don't let it overwhelm you. Work in your own lane. I view my lane here not as being, what's happening in environment or what's happening per se in healthcare. I view my lane as being in behavioral health. So the work I need to do is in behavioral health. And I would say probably most of you do as well here. So I think those are some of the principles that are important. We need to help our own colleagues get through this in a certain sense. And I'm sure you all know people who have had these experiences as part of this process going forward here, especially in the last 2 months, basically.
Yeah, thank you. Thanks, Ron. So really appreciate the words of really highlighting with energy advocacy and even as a moral responsibility for us to engage in processes that can influence the decisions that are being made in this process. And along with advocacy as a moral imperative, self-care as probably a moral imperative as well. And they sort of go hand in hand, that it's just so important for us to take care of ourselves and to build community and support with each other. And let me just ask, this is a question that's a little bit off our script here, and I'm going to this will be the last one before we open it up for questions from everybody else. But even before this tectonic shift that's been playing out, things were not, sort of peachy in our field, right? I mean, when we look at all the players, we look at counties and states that are oftentimes driven politically, insurance companies, which, although there are many, many kind, healing people at the insurance companies, at the end of the day, it's about margin, it's about profit. Private equity groups now obviously are interested in margin and multiples. And then there's the provider that genuinely, hopefully, creates environments for wellness and compassion. And then peers who walk hand in hand, sharing recovery and hope with those that they work with. So we're all navigating this maze or jungle or whatever you want to call it. And I would just because it sounds like you've done it well. And I'm going back into my mind about organizing things in the backyard or in the ball field. But I wonder if you could maybe say a few things about that, and then we'll open it up for questions from the group.
Okay. So I guess a couple general comments here. I think until the tectonic shift, behavioral health has been on a good path going forward here. And I can point to many things in the last 5 years that have developed that I think are moving us in the right direction. And they range all the way from 1115 waivers to states to improve state behavioral health systems. I do some work on that in California, so I'm familiar with what's going on in California. California has a huge 1115 waiver. They are using that to improve their county behavioral health systems, closed loop referral systems, performance measures, strategic planning, all of these things are going on. So one example. Another example would be the project I mentioned, I think earlier, from CMS on integrated care. That project needs to happen. That project has started, et cetera, et cetera, et cetera. The fact that we are now beginning to embrace peers as part of the delivery system in a big way. When it first started, there were very few peers there, and now there are many peers there, and there are going to be many more, and we're getting standards for peer services, et cetera, et cetera. So I think, bottom line, we're probably moving in the right direction here. I think another important thing is one of the things that binds together all of the groups that you mentioned, positive values will prevail here. I think most people at whatever level they work in behavioral health, and I don't care whether it's in a managed care company or in NIMH or in Positiva or as a private consultant, do this in part, at least, because they care about what happens to other people. If you didn't care about what happens to other people, you'd never be in these fields in the first place, basically. So I think that's a positive value that kind of binds us together in a certain way. And that creates hope for us for the future going forward here. So to go to the analog of the ball game and so on, we're like a little bit like a complex family here. Over my career, I would say at one point or another, I worked with all of the different groups that you talked about. And, I never said, well, I'm not going to ever talk to anybody from a managed care company. That would be foolhardy because, half of the system in California is run by managed care companies. Or, I'm never going to hire a peer, or I'm never going to hire a social worker, or whatever the situation is. That all of those kind of comments are foolhardy. And we're kind of a complex family, and we don't always get completely along, but we never completely leave the family either. And I think what's happening externally now, the external threat creates internal cohesion. And so I think we have more cohesion sitting here today than we had 2 months ago because of the external threats that we are being subjected to, basically.
Thank you so much, Ron, and thank you for your words, your wisdom, your work, and it's just been a delight to get to speak with you today. And I'll turn it over to Chris for questions any questions or curiosities or comments that the group might have.
Yeah, there's nothing in the chat, Ron, but I have a question, a direct one that relates to integrated care, CCBHCs, the tectonic shift that's happening, and the potential change with the Make America Healthy Again department and doing away with CCBHCs or not supporting them in the future. Can you speak to any of that?
Okay, so where do you want me to start? So let me start with CCBHC. So, and a little bit of history on CCBHCs. The CCBHC program is very much like the CMHC program. And if you remember the original Kennedy CMHC program, we started in 1963. By the year 1980, we had built 804 community mental health centers where we had a physical facility and we had programming. Ronald Reagan came along, we stopped the community mental health center program, never built another one. We only built half of the system. The CCBHCs are the modern variant of the CMHC program. Thus far, we've built, I think, something in the 490s, or maybe 490, 500 of these CCBHCs. And I think they move the agenda on integrated care in a way that the old CMHCs did, because they are literally required to provide not only behavioral health care, but also primary care. If they can't provide it directly, they have to have it contracted, et cetera, et cetera, et cetera. They also have more capacity to do more hiring of behavioral health providers than the old community mental health centers had, et cetera, et cetera, et cetera. So it's a good turn forward, and a lot of the states are interested in continuing this. So because the states are interested in continuing this, I very, very seriously doubt whether the proposal budget that has been put forth by the Trump administration for fiscal year 26 will include the item that's in there in the end. We're going to stop funding CCBHCs. So again, it remains to be played out, but I think in the end, it won't happen. There is a lot of support in the Senate Health, Education, Labor, and Pensions Committee for CCBHCs. There's a lot of support for the CCBHCs in the Mental Health Caucus in the U.S. House, which includes both Republicans and Democrats and so on. So I think in the end, that won't quite happen. Now, they may not fund as many, but I don't think it's just going to be taken down to zero, basically. And as I said, that whole program is a very important feature of moving the integrated care agenda. And I'm very interested in that. Some of the work I'm doing in California right now. So when California did not adopt the CCBHC model early, so they are coming later to the table of CCBHCs, and we're doing some work right now to help some of the county people in California understand how a CCBHC would operate in contrast to how a county system would operate, et cetera, et cetera. So we're actually working on that right now in my work in California here. But a very important question, and we need to ask that question not only about the CCBHCs, but about a whole bunch of other programs of regional and national significance that the Trump administration is trying to zero out from the SAMHSA budget for fiscal year 26. So there's a huge need for advocacy, huge need for getting organized and advocating these points. I know Chuck and Goglia from the National Council would be very happy to have the support of anybody who's involved here in the lobbying on the issue of the CCBHCs. They're a very important part of our future for everybody who's on our call today here.
Thank you. A couple other questions have come in. We'll see where you can go. Lots of thanks to you for your insights and wisdom coming in through the chat, just so you know that. So here's a question. I'm thinking about this. The arc of the moral universe is long, but bends toward justice. Any way we can speed it up?
Well, I think, how do we speed it up? We speed it up by what we do in this field every day. We speed it up by what we do, by bringing social justice to the poor. You know, one of the findings we've had in this field, and the finding is over 60 years old now. It was published in a book by Hollingshead and Redlich called Social Class and Mental Illness. The Hollingshead and Redlich study basically showed that people in the lowest social stratum have mental health conditions at 8 times the rate of people in the highest social stratum. And that work literally dates back into the late 50s, early 60s. Redlich, the co-author with Hollingshead, replicated the study in the middle 1980s. I was Redlich's project officer in the middle 1980s when he had the same findings in the 80s they had in the 50s. And I would say if you looked at the problem of our epidemiology today, you would find the same thing. There's a huge, huge difference in the rates of these disorders by social class. The poorer you are, the higher the probability is you are going to have one or more of these problems. Addressing this, the types of things we do, moving the arc of social justice, people in behavioral health do that every day of their lives. And again, I don't care whether you're an individual therapist or whether you're a manager of a managed care company. Part of what you're doing is moving that arc of social justice for the poorest, so the poorest can get access to some care, can get access to housing, jobs, etc., that they might not otherwise have be able to access socially. So I think that's just very important. And we do that every day in our work. And then what we've been talking about here several times during the conversation also is the whole question of we should be doing more advocacy, we should be doing more organizing, and we should be doing more advocacy for all the problems that have been befallen on us in the last couple of months. That's moving the arc of social justice as well. And I guess the third thing I would say about it here is it's important to set that example for our children in the United States. It's very, children have great difficulty finding role models in American society, or at least the kind of role models they probably should be finding. We need to be role models for our own children and grandchildren and nieces and nephews and others in doing these very things. If you want them to do these things and move the arc of social justice, you need to do it yourself, basically.
Thank you. We have time for one more question. There are a couple here, but we're going to do one. It seems, here's the statement in the question. It seems that medicating symptoms continues to be at the forefront of mental health treatment. What more can we do to elevate the importance of housing, employment, community connection, and relationships as key behavioral health initiatives?
Okay, so very, very important. So I think, I'm going back to where I started when, an hour ago. When we changed the paradigm of behavioral health from the chronic relapsing disease to trauma-induced disease with recovery, trauma-induced disease comes from the social and physical determinants of health in the environment. You cannot address trauma-induced disease if you don't work on those very things. And there's just a lot going on in that arena. We could spend another whole hour talking about things like developing community interventions. So how do I work with a community to create a self-empowered community that actually functions like a community? And there's a lot of work ongoing. The Hogg Foundation in Texas has done some of this work. There's work ongoing on this in other countries like Canada and the UK and New Zealand and Australia. And the findings are pretty much the same. When you get self-empowered, developed communities, those communities tend to be able to take on people who are developing behavioral health problems before they ever actually develop into behavioral health problems. Means we have to work with communities. Number one. Number two, we have to do what's called population health management. Population health management is nothing other than taking a population, subdividing it by the level of health in the population, saying, you groups here need different levels of intervention from us in order for us to preserve whatever health you have and to address. Population health management allows us to work with people to prevent them from developing trauma-induced diseases in the first place. And it's not fully being done right now, but it has that potential, and we can do that. So there are a number of tools here that can, and I guess the wraparound on all of this, you need to work a little bit with public health. Public health knows the strategies for doing these things, and I've been advocating for a while that we in behavioral health work more closely with our colleagues in public health because they can help us do some of these things we need to be doing here.
Ron, thank you. Thank you so much for today, for all of your insights, all of your wisdom, everything that everybody in the group is just nodding heads and commenting that, wow, thank you. And what a launch for the Transformative Elders Project. I can't thank you enough for that too.
And thank you for inviting me. Greatly appreciated. As I said at the beginning, if I can help any of you in any way, be in contact, and I'll be happy to work with you. Okay?
Yeah.
You're
Thank you
on.
so much,
Very
Ron.
good. Take good care.
Bye,
Yeah.
everybody. Thanks,
Bye.
y'all.
Take care.